We'll now be talking about a new topic called as daycare surgery. This was a concept which was in existence earlier but came into being only lately because the acceptance of daycare surgery, as far as the surgeons were concerned, they were very reluctant because you have to send back the patient on the same day itself. Now, it was introduced in 2001 in UK with the idea of modernizing National Health Service. What was the aim behind it? There were a lot of patients who were waiting for surgery, and the main idea was to reduce the waiting period, implement a booking system, and introduce a patient's choice. The patient's choice is not for the surgeon but for daycare surgery. But it met with a lot of constraints. Why? People were reluctant because they felt that the contact with the surgeon is not there. Then you have to go back with the same day. What will happen when you go home? What are the complications that are likely to happen? In UK, admission of selected patients to the hospital for a planned procedure and returning home on the same day. So the definition varies from place to place, whereas in UK, it's defined as selected patients who are admitted for a procedure in the morning and they return home on the same day. Endoscopy, where OT is not required, general anesthesia is not required, is not classified as a daycare surgery. In USA, it is defined as any procedure following which the patient is discharged within 24 hours, or it was renamed extended daycare surgery, 23-hour surgery, or ambulatory surgery. Whatever is the term, it means within 24 hours, the patient has to be discharged. Now, in view of the different definitions, it is difficult to compare statistics. In spite of this daycare surgery having come up in the United States and UK in a very high percentage, still in our country there are very few hospitals who cater to this daycare surgery. Main reasons is reluctance on the part of the surgeons and reluctance on the part of the patients to accept this form of or modality of treatment. Now, history of daycare surgery. If you look into the literature, it was in 1909 that James Nichol, a pediatric surgeon, did congenital hernia and cleft lip and discharged the patient on the same day. Now, in 1919, Rolf Waters, an anesthesiologist at Downtown Anesthesia Clinic in New York, did minor procedures and under anesthesia, and the patient returned home on the same day. But this concept came into being during World War II, the realization of drawbacks of prolonged bed rest and the complications like DVT. So in DVT, the dictum is early mobilization. So this actually in 1955, for Carson, who has written a textbook of surgery, did 455 cases of inguinal hernia as daycare surgery. So these were the pioneers who initiated this technique. Now, what is the main advantage? The problem in the Western countries is everything is met by the insurance companies. And if you keep the patient in the hospital for a longer time, the bills go up. And the waiting period is also long. So in order to counter these problems, it was decided to conduct what you call daycare surgeries. It was first implemented in United Kingdom, United States of America, Canada, and Australia. By 1970 to 1980, more cases came into being. Medical insurance curbed rising health cost. Now, the problem that they had to face was daycare surgery was held in low esteem and it was unpopular. Many people tried to oppose it, saying that what they wanted was because they have to have someone to look after them at home, and in the Western countries it's a very difficult proposition. So it was unpopular. People felt that it would be better to stay in the hospital or in the ICU where they got better care. Now, cultural changes were required, and by 1985, the number of daycare units in UK increased. People gradually started what you call daycare surgery units. In 1992, the Royal College of Surgeons published their guidelines for daycare surgery. And the BADS is nothing but the British Association of Daycare Surgeons. And as a result of introduction of daycare surgery, the cost factor markedly decreased. That means the amount spent in hospital was markedly decreased, and as per the audit, 80% patients opted for daycare surgery. That is a remarkable response, change in response after a lot of opposition to this procedure. Now, in 2001, they selected certain cases for daycare surgery, of which they were circumcision, orthodoxy, fissure in anal, varicose veins, transurethral resection of the prostate, inguinal hernias, breast lumps, piles, lap cholecystectomy. Lap cholecystectomy, there were certain problems in the initial phases, but later on it has been recognized to be taken up as daycare surgeries. Now, one of the major things is you should have a facility for daycare surgery. Daycare surgery should be entirely different from your planned surgical units. You should have a theater, a post-op recovery room, and a pre-anesthetic, what you call chamber. The importance is the patient is fully assessed, investigated, and checked prior to surgery. Patients arrive on the morning of surgery, they are discharged on the same day, and it's a pre-planned admission episode. Now you must be wondering how these things go on. Basically, the general practitioner has an important role in daycare surgery. They are the ones, along with the junior doctors, who assess, take a clinical history, give the investigations, and the patient is referred to a particular daycare unit from where they are given a date for surgery. They just walk in on the morning of surgery, and after surgery they're discharged on the same day. That means everything is pre-planned. Now, initially what used to happen? You used to get admitted in the ward. There was a lot of problem of bed availability. Service was poor, and self-contained day units started, independent theatre and recovery unit. In the initial part, when the number of patients waiting on the waiting list were very high, they had to inquire about bed availability daily, and the service was poor according to them. But once they started the daycare surgery, it was actually self-contained units, day units. They had an independent theatre and recovery room. So everything was monitored and streamlined. All that the patient had to do was walk in, get his surgery or her surgery done, and walk out. Now, what is a daycare cycle? You select patients from the waiting list, direct them through surgical OPD, investigations and medical assessment are done. Fast tracking is done by the general physicians, and surgeon sees the case on the day of surgery. Sorry for the spellings. This is the main problem that we had to face initially. So the problem is the surgeon sees the case only in the morning. So one of the complaints that most of the patients had, the rapport between the surgeon and the patient is very much less. It's the GP or the general practitioner who works up the case, and the surgeon sees the case on the day of surgery. And it is actually, they say, it is suitable for young, straightforward surgical cases. If you have a complication, they would always select you for an admission, but straightforward cases are suitable for daycare surgery. Now, patient selection, you have to be very careful when you're selecting your patients for daycare surgery, because age is important. Obesity, particularly in the Western population, obesity is a problem. Do not select obese patients for your listing, medical fitness is required because a patient with CAD or any other ailment needs a medical fitness prior to surgery. But the daycare surgeons were not so rigid in selection. Up to ASA class 3 patients are accepted. Now, the American Association of Anesthesiologists has classified class 1 as healthy, class 2 is mild to moderate systemic disease, hypertension control, mild DM and asthma, class 3 systemic diseases like hypertension, diabetes, and history of myocardial infarction at least 6 months earlier. So patients up to class 3 were taken under the category of daycare surgery and they were evaluated. Class 4, cardiac, pulmonary, hepatic, renal insufficiency. Class 5, not expected to survive 24 hours after surgery, were not considered for daycare surgery. So a selection of cases for daycare surgery was a must. You had to evaluate the patient, and till American Society of Anesthesiologists criteria 3 patients were taken up. Other patients were asked to come for admission and the patient was taken after admission. For daycare surgery, good selection. Obese patients were not taken up for surgery. Age, social factors, the BMI, smoking and medical conditions were evaluated in detail before posting them for daycare surgery. Now, pre-op assessment, it's called as DOSA, that is day of surgery admission. A questionnaire is given to the patient. He or she is asked to answer the questions and the patient is screened by the junior doctors and nurses. So on the day of surgery, the patient walks in, he's given a questionnaire, he's asked to fill it up, which is scrutinized by the junior doctors and nurses. Routine investigations are checked: hemoglobin, total count, differential count, RFT, urine routine, ECG is mandatory if there's previous chest pain, X-ray chest is not needed. Actually, I don't know how many of these patients can be taken up in our setup where you need a battery of investigations and a battery of subspecialty references. So the advantage of daycare surgery is minimizing the number of investigations and doing only certain investigations that are needed. On the day of surgery, the surgeon sees the patient, verifies the contents and consent and details of surgery. Pre-anesthetic checkup is done on the day of surgery in the theatre. There is no question of the patient being admitted or seen before by the anesthesiologist. That is one problem that most of the what you call daycare surgeons face. They see the case only in the morning, and the anesthesiologist also sees the case only in the morning. And the prior requirements are no solid diet for 4 to 6 hours before surgery. Up to 300 ml of clear fluids can be given 2 hours before surgery. Because today the principle is ERAS, early recovery after surgery. So you should feed at least 300 ml of clear fluids till 2 hours before surgery. No solid diet 4 to 6 hours before surgery. And the patient is usually discharged 18 to 24 hours after surgery, and surgeon anesthetists see the patient before he's shifted to the recovery room and before the time of discharge. Now, what are the criteria for discharge? You check the vital signs: pulse, respiration, blood pressure. Oral analgesia is given, whether the patient is correct orientation or not. Post-operative nausea or vomiting present or not. Look for bleeding. Look whether the patient has passed urine. Start oral fluids and advise care at home for 24 hours and give an emergency contact number, and follow-up data is mentioned properly. All these things have to be mentioned in the discharge summary. And before you discharge, what you look at is the vital criteria: urine output, bleeding from any side, has the patient started oral fluids, post-operative nausea and vomiting. As far as the procedure is concerned, they don't give any pre-medications. That is one of the advantages here, and it's given only for apprehensive patients, and routine medications are usually given. sedation, techniques of usage of drugs which depress the CNS, enabling procedures to be carried out with verbal contact with the patient being maintained. So minimal sedation, and as you do the procedures, you can talk to the patient and the sedation is very much less. What they use mainly is midazolam or pseudoanalgesia comprising of benzodiazepine plus an analgesic, pethidine or morphine, or short-acting fentanyl is used nowadays. Local and regional anesthesia using lignocaine, bupivacaine and ropivacaine. Nerve blocks. Nerve blocks have revolutionized many surgeries, and most of the surgeries are done under spinal anesthesia. Those with obese and CVS and pulmonary problems with below waist surgery, they always opt for spinal anesthesia. So daycare surgery has revolutionized surgery. General anesthesia in selected surgeries only. That is, in 1999, the criteria for GA in selected surgeries were lap hernia and cholecystectomy, submandibular gland excision, thyroidectomy, superficial parotidectomy, wide lump excision, lump breast, piles, urology, and arthroscopy. So these were the indications in and ENT procedures for what you call daycare surgery. Breast, piles, gallbladder, prostate, laser, tonsillectomy. Tonsillectomy is a controversial issue because you need general anesthesia for it. Now, in the daycare expansion, there is a pre-assessment, expand patient selection criteria, because earlier we had selected only certain patients for surgery, but today they are expanding the criteria and most patients are coming into the what you call daycare fold. So number of waiting cases are reducing, the amount spent in hospitals is also decreasing, thereby the the insurance companies are also helped to a maximum. Alternative anesthetic methods are tried like blocks, regional anesthesia instead of general anesthesia. New technologies in surgery like arthroscopy, etc. are being used. Organization, redesign, and today the role of non-medical practitioners to help surgeons is being tried to reduce the number of staff, particularly qualified staff, and to lengthen daycare surgery. Key points is 75% of all cases of surgery can be done under daycare, pre-op assessment earlier, daycare admission to be independent, use local and regional anesthetic, and lab TUR can also be done under regional anesthesia. Now from the OT, there's a first stage of recovery, that is vitals, reflexes are normal, and he obeys commands. Second stage is pushed into the recovery room, and third, discharge criteria fulfilled like passed urine, taking oral fluids, no pain, no post-operative nausea, vomiting, and all the vital parameters are within normal limits. And this is the condition which we need for, and there are no unplanned overnight admission. Most of complications that can take place, major ones are visceral damage, hemorrhage, myocardial infarction, pulmonary embolism, cerebrovascular accident, respiratory failure, etc. Minor pain, vomiting, drowsiness, headache, and minor bleed. So in a nutshell, daycare surgery is taking over now, but still it's in the what you call infancy in India. It is very difficult to accept for an Indian to accept daycare surgery. What we feel is that if we go home and some complications develop, it's going to be a problem. And surgeons are also very much afraid to institute this practice in their institutions because today litigations are going up and doctors have to be very careful. If you discharge a patient and he lands in trouble, you're also in trouble. So daycare surgery is the talk of tomorrow. Thank you, ladies and gentlemen, for the patient hearing.